This is Dr. Corey Glenn, and I'm going to go over a case that we did yesterday up at the Hope Smiles Clinic in Nashville. And try to keep this pretty short, but we did an all-on-X upper. We did 4 implants in the maxilla, and then did an immediate load conversion using photogrammetry. So I'm just going to go through how we did the case, and then also I think there's a good tip in here on intraoral scanning. If you've ever tried to scan in a bloody surgical field, you know that that can be problematic. So I'll show you how we address that. So this was the patient's initial presentation. She came in, she had only 3 upper teeth, decent amount of lower teeth, but she had quite a crossbite. So she's in this kind of acquired class 3 just because the teeth don't fit together properly. And so obviously there's a lot of room for us to make improvements on this. Plan was to do implants and to do a maxillary full arch. So quick shout out to Dr. Andrew Byram. He was the treating doctor on this case. Andrew's 1 year out of school. He's one of the residents up there at the clinic, and just gotten to do some amazing stuff in this year. Dr. Clayton Singletary is the residency director there, but great program. If you're coming out of school, I'd highly recommend it. But this was Andrew's. He's done a lot of implants, a lot of full arches, but this was going to be his first full arch immediate load. All right, so I approach every single one of these cases the exact same way. It doesn't matter how simple, how complex. I'm always going to start with pictures, right? You've got to figure out where teeth belong in the face before you can really treatment plan things properly. So for me, this is my system. I always start with just a quick and dirty smile analysis in PowerPoint. And so this template's available on my website if you want to purchase it. You can do smile simulations and everything like that. But basically, I'm going to pull their face in. I'm going to align it behind these lines. So I'm going to get these green lines parallel to the inner pupillary. I'm going to get the facial midline set, which is the red line. And then the other green line is just a duplicate that I'll pull down approximately to the level of the teeth so I can visualize the occlusal plane and any cants. There's a little thing that you can use to outline the lower lip because you kind of want to make the maxillary teeth follow the contour of that lower lip. And then finally, there's a little golden proportions ruler right here. So I'll scale that. The blue lines are the width of her nose. And so I'll scale the edges of that. And that basically gives me a frame into which the teeth should fit if I do a simulation and then subsequently do a prosthetic wax up. And so we did this, and you can import all of those same lines and everything into Blue Sky Plan, into ExoCAD. I'm doing the wax up here in ExoCAD. So now I've cut everything out from between the lips. I've got my grid of here's where the teeth belong. And so now I'm going to go ahead and do the wax up. And so you can see I've brought in her maxilla from Blue Sky Plan, which I segmented there. But basically I've just brought the teeth in. I'm setting them to the lower arch, but I'm setting them according to the lines that I've generated in PowerPoint. For me, that's just a dummy proof way to get a nice, good aesthetic outcome with your prosthetic wax up. And, there's still an art to it, but it really simplifies the process and makes it where there's not such a big learning curve. These things are simple to do. So if you can build that grid, and now that tells you, okay, put the teeth here. For me, that's a much more straightforward way of accomplishing these cases. So this is the prosthetic wax up, as you can see. And then once I had the wax up done, so I have the occlusal surfaces and the incisal edges, all of that where it belongs, but we're going to be doing this as an immediate load, and it's going to be an FP1. So I also want to now take a bit to contour the pontic form of it. So like back here in this area, you can see those pontics need to come up closer to bone. In the anterior, these pontics need to be relieved so they're not so close to bone. And in general, I'm trying to get those pontic forms about 2 millimeters away from bone. That's going to be enough room for her tissue to reside, but not so close that it chokes it out and you get bloody, angry tissue with it. And so the upper right green image, that's the final contoured wax up. And all of this is being done preoperatively, remember, all right, because I want to get everything dialed in. I don't want to plan implants until I know where these ideal teeth belong. So I do all of this on the front end, and that makes the rest of the case go that much easier. So once I have that wax up, now I'll just export it, take it back into Blue Sky Plan, and now I'm going to do the implant planning backwards from my ideal teeth. And so you can see the positions that we came up with. We're trying to avoid sockets where possible. And so we were able to get two implants in kind of the number 7 and 10 areas. And then we got a couple more by distoangulating, avoiding her sinus. We got those in roughly the first molar area. So this is what drives my implant positioning. Could I have placed the implants without seeing this? Sure, you could have, but then later on, you're trying to figure out, okay, well, now the implant's here. I'm going to have to use such and such multi-unit. I just don't like those surprises. I think the better way is figure out the endpoint, which is the teeth, and then work your implants backwards from that so that you know you're going to be in the right position to get a good result. So these were the final implant positions. And then based on that, we just decided the simplest way to get the implants there is just to make a very basic bone supported guide. So nothing special here. This is just a guide built directly on the maxilla, 3 lateral retention pins, and this is going to be used in the Blue Sky Bio fully guided keyless kit. And so this is all Andrew's surgery and photos and everything. So did a nice job of reflection. Most people I find if they're struggling with guides for full arches at least, especially bone supported, it's because they're not reflecting enough. That big flap is going to heal just as quickly as a small flap. So just go ahead and flap it aggressively, get the tissue out of the way. And you can also do a tie back like what Andrew's done here. And that really helps your visibility and it's going to make putting that guide in a lot easier for you. So with the tissue reflected, he was able to seat the guide. It had a really nice indexed fit, and you can see the bony windows that we are fully seated on the bone. That's a very important step for any guide is to make sure it's completely seated on the bone. And then once it is, now you can drill your pinholes and pin the guide in place so that you don't have to hold it the whole time. So it didn't take a lot of pictures midstream in surgery. Basically we took the drills through the guide, made the osteotomies, and then the implants were guided into place. And then we knew from the pre-op planning that these back 2 implants were going to be using 30-degree angled multis. The front 2 implants were going to be straight multis, and I believe these are all 3 millimeter lengths. So here's the MUAs in place. And now we're ready to start doing the process of the conversion prosthetic. Again, we're trying to do this all same day. You could do next day. A lot of people do that. Danny Doming, who I speak with a lot, he prefers just to deliver it next day. I'm traveling back and forth to Nashville, so I wasn't going to be there. So it just made sense for us to do it the same day. So if you are going to do this with a photogrammetry approach, and in this case, I'm going to be demonstrating using the Grammy unit, which Blue Sky Bio sells, but they're all going to be roughly the same type of workflow. All right. So you're going to first of all do an intraoral scan. And here you see the intraoral scan bodies for the Grammy. These just go directly to the multi-unit, screw in, and you would take your intraoral scan. Now, as an alternative to that, and we'll talk about this when I get to the scanning, but it can definitely be difficult to get a scan with your intraoral scanner in a bloody field. Some do better than others, but a lot of them really struggle in a bloody field, especially if it's continuously oozing. That's essentially changing the topography of things. Plus, it's shiny. So if you didn't want to do an intraoral scan, your other alternative, and this is what Danny does, is he'll just have his assistant step in, take a quick alginate of these, and then that can be poured up, and that serves as a model which you can scan very easily because now it's in stone, it's not shiny, it's not moving, and you get to the same end result. So that's certainly an option. You could do an impression of this, pour it up, scan that. All right. Or you could just do the direct intraoral scan if you've got a good strategy of how you're going to approach that. And that's what I'm going to show in the next slide here. So we'll do the intraoral scan with the scan bodies, and then those come off, and now you put on the photogrammetry scan bodies. All right. So these are the ones for the Grammy unit. They're just these black and white kind of fat posts. And then you would do your photogrammetry scan. So your intraoral scan, it's going to be close and it has the tissue and stuff, but we expect it to not be really all that accurate because you're going to get distortion across those larger edentulous spans. Again, it's a bloody field. So we expect it to be close, but not perfect. And, close is not good enough for doing a passive full arch restoration. Hence why we do the photogrammetry scan. Think of this as your digital verification jig. It doesn't pick up anything except the implant positions, but it does so very accurately. So in the end, we'll take the data from the photogrammetry, stitch it back here, and basically overwrite the positions of the scan bodies in the intraoral scan. All right. So once he had done his scans, now I take all that data. I'm doing the conversion on the computer, and Andrew went ahead and started placing his PRF slugs. And so what we like to do is just punch a hole in them, drape them over like a poncho on top of each multi, and then whatever extras you have, just really lay across the ridge. You want a good fat bed of PRF, ideally, if you've got it, because we're not going to attempt to get primary closure. So having all of this PRF is going to make a nice barrier between the bone and the temporary. It's going to get sandwiched down by the temporary. And then because we haven't gotten primary closure, that's all going to granulate in. So you end up with a huge gain in keratinized tissue. And here is that closure. All right, so Andrew was doing all this while I was doing the conversion on the computer. You can see pretty loose. We're not trying to get primary closure because, first of all, how are you even going to get your temp seated? Remember, we've designed an FP1 temp. It's properly contoured to the bone, so we want to leave the room that this temp can seat down and then force the tissue to granulate in around that. Think of the same way you would do a single tooth with a healing abutment, right? You wouldn't try to get the tissue completely sutured closed around it. You would leave it a little loose around that, and you would know that as it heals, it's going to take on the shape of that healing abutment. Well, again, this is something me and Danny have published on. We're treating this like a full arch healing abutment. Create the contours you want, and then force the gingiva to heal to that. All right, so that's the surgical portion of the case. So here's what I wanted to show you is when we first started doing the intraoral scan, you're going to see that the scanner has some problems. Okay, and this is a very common situation. You see how it just tracked back and it's trying to build this new model because you don't have a ton of topography to reference off of. You don't have teeth here. All you have is this big ridge, which is very similarly shaped in spots, plus all the blood. But the only distinct things are those scan bodies. And so it scans them, and then you get to the next one, and a lot of times it has trouble tracking, and it thinks you're back on the previous scan body. So it starts rebuilding your model from there. And so you just end up with these very distorted models. And so what we did is we took a different approach. We actually deleted that scan and then just approached it a bit different. And so I want you to imagine, just looking here at my screen, this is her arch. Of course, there's no flap here, but for visualization's sake, I think this will serve the purpose. Imagine that my select tool here is the head of the intraoral scanner. All right. So the way we got past that is we started by scanning the whole palate. All right, because that's going to stay stationary. There's nothing that's going to try to track back and throw you off and rebuild the model. So imagine you scan across all of this. All right. Now you have this area, which is a very large kind of known surface. Now, how are we going to pick up our scan bodies? So once you've got this, now we're going to scan out and across the area of the scan body. And instead of going now from there to here, because again, it might get to here and jump back thinking you're on this scan body. No, instead of that, we're going to track back into the area we've already scanned. And then we're going to go from there back out to the next scan body. And then we'll track back from there, back to the known area, and then back out to the next scan body, and then back to the known area, and then back to your next scan body. And once you've done that, now you've built this model that has all of your scan bodies in the proper position. And all that you need to do from there is just go ahead and fill in the little gaps. And generally, once you've gotten to this point, you could kind of take this approach where you just go across the arch like so and pick up all the remaining data that you need. And so that's what we did. And so here we didn't record the entire intraoral scan, but you can already appreciate how much better this is. All right. He's just done the whole palate. Now you see he's going to go back. He's going to reach out, capture that scan body. All right. And then he'll track back into the known area, grab the next one. And as you do that approach, it's going to build a much better model. Now, it's still missing a couple little holes because that's areas where there's bone sockets from the teeth, and you might have blood pooling or whatever. So that's why you're seeing a couple holes in it. But the result was we got a nice scan out of this. And then finally, after we've done the intraoral scan, right, we've got the approximate positions, I'll call it. We know they're not accurate enough. Now we're going to do the photogrammetry scan. That's going to be our intraoral verification jig, essentially. And so I'll just let this play. This is about a 15-second scan. So I just started it. I'm pushing the button with the Grammy scanner. Notice that it is wireless, so I don't have cords and everything. It's very easy to hold. And I'm just going back and forth at a correct distance. And the moment it's done, you'll see the light goes off. It kicks you out, and it communicates wirelessly to the computer. We've captured all the posts, and then that's it. All right. So very simple to use on the photogrammetry scanner. And that's, for what it's worth, that's the most affordable photogrammetry scanner on the market. Again, it does a nice job. All right, so this is the resulting data. You see, this was the intraoral scanner scan with the scan bodies on it. And again, I don't care that there's holes or anything like that, right? I was just trying to get the approximate positions. I do have the known tissue here in the palate, which is going to be pretty much the same as what her pre-op was, because we've always got to think about how are we going to get this final data with your implant positions, get that all back to your pre-op data where your wax up was, because that's what you're going to have to convert. A lot of times we'll use a fiducial marker in the palate, which is going to get scanned and that stays in place even after teeth are removed. Sometimes we'll strategically leave a tooth or two, do intermediate scans. I've shown that in previous videos, but here, because we didn't distort a lot of the palatal tissue, our incision was made very palatal, and we didn't really have to reflect all that much in the depth of the palate. So I felt pretty confident I could use that anatomy to stitch back to her preoperative intraoral scan. And that's how I was going to get everything back in position. So this is your intraoral scan. This is all the results from that Grammy scan, from the photogrammetry scanner. It doesn't pick up tissue. It doesn't pick up anything except for your multi-unit abutment position, but it does that very, very accurately. Okay, so now with those pieces of data, I can pull it into exocad. I'll usually start by pulling the surgical intraoral scan back to all of her pre-op data. Just do a best fit match. Again, I'm using the palette here. So now that's positioned correctly. Now I'll bring in the photogrammetry scan bodies. Now these are the same scan bodies in both scans, and you would just best fit match. So you would put a dot here, and then put a dot here, put a dot here, a dot here, a dot here, a dot here. exocad wants 3 points, and using that, it will best fit match those. And what you'll expect to see is that it's going to be a good stitch, but it's not going to be dead on perfect, right? Because again, we expect this intraoral scan model to be somewhat distorted. And so by doing that, we are overriding these scan body positions. Those are only used for pulling the photogrammetry data to it. But we're overriding those positions with these very precise photogrammetry positions. And once you've got that, now you can proceed with your normal exocad 3-shape workflow, whatever you're using. In this scenario, I'm using Danny's Vortex screws. I like those a lot because I can go straight to the multi-unit without the need of a tie base. They're long enough that I can still have thickness under the material so it doesn't just, break through as I torque the screw in. And they give you about 20 degrees of angle correction. So I just see no downside to them. They're really nice for these types of cases. All right, so remember, we pulled all of this stuff back to where we had our pre-op data, right? Her maxilla, her mandible, which we had recorded in centric. And so now the idea is the wax up already exists. We don't want to start over with a new wax up. We already spent the time to do that well pre-operatively. Rather, what we want to do is just identify our scan body positions, tell it we're using vortex screws, and just make it build in the screw channels and the screw seats into that FP1 wax up that I did earlier. And so here you can see I've done that conversion. I had to bulk out some areas where, it just needed to be thicker. But aside from that, I didn't have to do anything. We just simply built in the screw channels, and this was the final result. You can see on the bottom right, these go direct to the multi-unit. Once we had that file, we just sent it to the printer. one of the printers I have and the one that they've got at the Hope Smiles Clinic is the Shining 3D AccuFab Cell printer. I really like this one a lot. It's very fast. The print yesterday when we did it was about a 16-minute print for these teeth. So very efficient. I used a permanent crown and bridge resin, printed this out, and all you're going to have to do really is remove any little support sprues, and then I always try to take a little reamer through the holes just so that I know that my screws are going to go to seat. You can clean those out with some alcohol and a little tiny pipe cleaner on a wire, proxy brush, whatever you want to do for that. Um, Polished it, and it's ready to deliver. And so Andrew went back in. Remember, he's done a loose closure and he's going to deliver these and screw them down. I don't usually try to torque these into any particular value at this stage. We're just going 2-finger tight usually. But here you can see the final cone beam X-ray. Those are lip studs. They keep throwing me every time I look at this image. But you can see a beautiful job on the implant placement. Everything is perfectly within the bone where we planned it to be. And, she originally had that class 3 bite. We were able to bring that out and give her more of a class 1 relationship. Now we'll see how the gingiva heals. I anticipate I'll probably have to, bring my Pontics lingually back towards the tissue a little bit. But for a same day conversion, this is perfectly fine. And what we're trying to do is get the tissue to force itself to heal to these pontic forms. And that's going to give us that nice scalloped tissue and a natural looking emergence out of this. So that was the case. You can see this was her before picture that we took that morning. And then we had this delivered, I don't know, 1, 2 o'clock, something in the afternoon after we'd done the surgery. And she just hung out for an hour or so. And left with a much better set of teeth. And I do see little issues that I'll fix. It does look a little bulky to me, which is again why I say I'll probably bring some of that back from where it was. I love the tooth positions, but it might be that she's got a bit of a skeletal class 3, and so we'll try to correct that a little bit. Might even end up in an end-to-end final position. But that's the beauty of this is I can print as many prototypes as we need. I can try all types of crazy stuff because it costs me nothing. All it costs is just tweaking the design, printing that. I'm not using tie bases. I use the same 4 vortex screws, and we can just really dial this in prototypes until everything's perfect. And now that we know this is where we want to get to, we just simply process that into zirconia or PMMA or whatever it is that you want to use as your material for the final restoration. So that's it for this case. Hopefully I kept that relatively short and you learned a couple of things. But if you're interested in learning more about this stuff, I do teach courses. Go to my website, coryglenn.org. Got a denture course coming up. Got another full arch course coming up later on in the year. And then I'll be posting several other dates pretty soon. Anyways, hope you found that helpful. Thanks.